and healthcare reimbursement. Fiscal planning is not intuitive. It's a learned skill that improves with practice. Um, an important but often neglected dimension of planning. So this can be very intimidating for nurse leaders. It seems foreign until the leader learns about the process. So there are many managers that procrastinate on tasks related to fiscal planning, budgeting, because it can be overwhelming and it can seem like a daunting task. However, the longer you wait, the worse they become. So it's important to stay on top of budgeting and fiscal planning. Planning should reflect the philosophy, goals, and objectives of the organization. We kind of talked about that a little bit when we talked about organizational planning. It's a skill that's increasingly critical to nursing managers because of increased emphasis on finance and the big business of healthcare. Remember, in our previous lectures, we stated that healthcare is indeed a business, but managing the fiscal side of patient care includes improving patient care while being responsible with with financial resources. So you could ask yourself the question, what are some ways that nurse managers can demonstrate responsibility with financial resources? And some of those ways are to develop and adhere to a budget, efficiently allocate resources such as staff and equipment, and implement evidence-based practices that reduce cost. And, we can plan as much as possible, and things still may happen where we have to be flexible. And so just remember in the planning, whether it's budget planning, organizational planning, that you want to be flexible. So what is a budget? A budget is a plan that uses numerical data to predict the activities of an organization over a period of time. Just like your parents told you, money does not grow on trees. It does not. Each year, nurse leaders are asked to participate in formulating a plan for meeting the budget for next year. Okay, so you can ask yourself, what are some things that managers should consider when making a budget? And we talked about it a little bit. So they want to look at the data from the previous years. How much did we spend last year? Was it more? Was it less? So we want to plan accordingly. It may always be in the best interest to plan for a little extra depending on the organization. You'd rather have more than enough than not enough. And then you want to predict what will be needed in the upcoming year. Okay. So there are different types of budgets. There are 4 types: incremental budgeting, zero-based budgeting, flexible budgeting, and performance budgeting. And then these methods are on your or in your textbook on page 238 and 240. So make sure you take those. Incremental being the simplest method. Zero-based does not automatically assume that because a program was funded in the past, that it will continue to be funded. That's why a budget should be presented every year or every fiscal cycle, depending on what organization. And then, of course, your flexible budgets that flex up or down depending on the volume. And then performance emphasizes outcomes. So, your budget is based on the outcomes. So just make sure you take a look at that on page 238 to 240. Then we have cost containment. Cost containment refers to the effective and efficient delivery of services while generating needed revenues for operations. It's the responsibility of every healthcare provider, and the viability of most healthcare organizations today depends on their ability to use their fiscal resources wisely. And so here, why is it important for healthcare organizations to use their fiscal resources wisely? Well, quality of care. We want to make sure that we're providing quality care to our patients. Efficient use measures ensures, funds are directed towards improving patient care outcomes, because everything, that we do in healthcare is toward positive patient outcomes, financial sustainability, compliance, at risk management. Okay, so just remember those. Some services are more profitable than others and will carry the load for less profitable departments, but that may not always be the case. Many times leaders will have less discussions when asking for big ticket items such as MRI scanners or different types of equipment. Cost effective means producing good results for the amount of money spent. Absolutely. So if it's worth the cost to produce good results, positive patient outcomes, we're going to spend the money. This does not always mean the least expensive option, but also remember, and you've heard the saying before, you get what you pay for. For example, you may have a copier switch that's out. The company told us about the Cadillac version to get the sale, but sold us the Yugo, if you remember Yugos, small cars. But that's what cost effective means. Responsibility accounting. So each of an organization's revenues, expenses, assets, and liabilities is someone's responsibility. Okay. Ultimate responsibility is on the nurse leader. The ultimate responsibility is on the nurse leader, who will have to speak for the shortfall. So if the budget comes up short, or if they overspent for whatever reason, that's going to be on the nurse leader. As a corollary, the person with the most direct control or influence on any of these financial elements should be held accountable for them, and usually the leader or manager, which is what I just stated. So a good leader shares information with the team, and we talked about that a little bit in lecture last week, and is able to share the responsibility with the team. So if the team is aware, be mindful, of how we're using our resources and making sure that we're making good use of our resources. So just remember, managers are responsible for the budget in all aspects, not just a part of it, but they are responsible for all aspects of the budget. Healthcare is labor intensive, as we're nurses, or you all are soon to be nurses, and we understand how much work it is. The personnel budget accounts for the majority of most of healthcare organization expenses. So we spend most of our money on personnel. People are our greatest asset, right? So personnel is where we spend the most money. This includes productive and non-productive hours, productive work and in service. Non-productive includes paid time off, vacation, sick leave, and jury duty. So how do we calculate nursing care hours? So calculating nursing care hours, this is an example here. So make sure you take a look on page 235 in your textbook. So man hours per stat based on patient census, PPD per day. Patient flow is reflected here. So 1 minute after midnight counts for the next day. Sometimes involve case mix, index, and acuity levels. So that's on page 31. So please make sure you look at that. And you can see it on here as well, the formula for calculating the nursing care hours. So all right, supply costs. Next to personnel costs, supplies are the second most significant component in a hospital budget. We cannot do our jobs as nurses if we don't have the proper supplies we need to provide quality care to our patients. Supply costs can really put a burden on a budget if it gets out of hand. And so that's why it is ultimately the manager's responsibility. But if we share with the team or the staff the importance of using our resources wisely, they can also be aware of the importance of maintaining our budget. A good practice is to share with nursing teams how much items cost, because sometimes we use things we don't realize how much they cost. Before DRGs, and we'll talk about that, diagnosis related groups, patients were charged for every single item. You can go to page 232 in your textbook for further explanation on that. Um, so, what is the challenge with this? If patients are charged every single item, nurses were too busy to document the item, and so we're not keeping good track of what we're using, and that's probably increasing the budget for sure. So it's important for us, um, or whoever in the organization, to be cost conscious. Operating budget. The operating budget reflects expenses that flex up or down in a predetermined manner to reflect variation in volume of service provided. This includes personnel and supplies, right? Operating. How do we operate day to day? We need our personnel, we need our supplies. For further explanation on that, you can refer to page 237 in your textbook. Capital budgets. Plan for the purchase of buildings or major equipment. Okay, so this includes equipment that has a long life, usually greater than 5 years. So equipment such as beds, furniture, patient care equipment, monitors, so your high ticket items. Many times there's a wish list. I know in the military we always had a wish list. That way, if funds became available, we don't have to think about it. We already have a wish list of things that we want, and these are the first items to go when the budget comes up short, because it's on a wish list. So also having that in reserve in case we get extra money. But on the flip side, these are the first items to go because they're just a wish, right? There's equipment that we need that are must-haves, and there are some that we would like to have. Okay, so now that we've talked about fiscal planning and budget, let's take a trip through time. Where was health care typically provided in the early 1900s, and who was providing that care? So much of the care was provided at home. You had the doctor that had, his or her little black bag, and would go, to the patient's homes to see them. Home births, which there are still many home births, doctors' home visits for illness. What happened in the early 1930s that changed how we pay for health care? Birth of the blues. So Blue Cross and Blue Shield, so 1929, and then 10 years later, 1939. So the first, health insurance plans. Baylor University offered 1,500 school teachers up to 21 days of hospital care for $6 a year. My, how the times have changed. First HMO, Health Managed Organization, established at the Ross Luce Clinic in Los Angeles, California. Well, this is just a little bit of history. What does fee for service reimbursement mean, and how did it contribute to spiraling healthcare costs? Okay, so reimbursement system whereby insurance companies reimburse healthcare providers, a billed amount for services after the service. A lot of times nowadays when you go, they want you to pay up front, um, especially if you don't have insurance. Okay, there's still, so these are still used for many areas of healthcare. Many insurance companies require pre-authorization for services, especially for, or particularly for specialty care services. For example, a dermatology referral. You have to get a referral, you get authorization, and then you're able to go. Especially expensive ones, right? So must document necessity for service before approval is provided. So Your primary care physician typically documents that this patient needs this because of a serious issue. So that has to be documented before that approval is done. So third party payment for healthcare escalated from less than 20% pre-World War II to 70% by the early 1960s. So third party financing of healthcare, usually an insurance company or government agency, acts as that third party. What happened in 1965 that changed healthcare in the US? Passage of Medicaid and Medicare laws resulted in 50% growth in medical schools. What was the immediate impact of the creation of Medicare and Medicaid? Healthcare costs skyrocketed. And when you think about healthcare costs skyrocketing, we have Medicaid and Medicare. How long do you think that's going to last? Healthcare is expensive, right? So it skyrocketed. We created this Medicaid and Medicare, but is it sustainable? So more Americans had access to care. Although the healthcare costs skyrocketed, more Americans had access to care, which is a good thing. Providers saw this as deep pockets. Of course, more Americans have access to care, we can see more patients, we can make some money. Government forced to start looking at reimbursement. Today, they are considered the gatekeepers of reimbursement decisions because the government sets and enforces the policies that determine what services are covered and how much will be given for reimbursement. They are regulated by Centers for Medicaid and Medicare Services, the Joint Commission as well. So Medicare was established in 1965 for primary population. Primary populations are older adults, people with disabilities, and renal dialysis patients. And we know we've all heard there's Part A and B. Part A is funded by Social Security and federal tax. Part B subsidized 75% by federal government and 25% by prescribers. And this is financed primarily through employee payroll deductions and employer contributions. And then it lists here what it covers, which is inpatient hospital care, limited skilled nursing facility care, home health, hospice. Okay. Although beneficiaries pay a deductible for each inpatient benefit period as well as coinsurance for hospital and skilled nursing facility stays. So even though there's a portion covered, beneficiaries are still responsible for paying. Okay, financed largely from federal general funds. It is a supplementary medical insurance which cover primary care providers and outpatient diagnostic tests and certain supplies and equipment. It is optional for beneficiaries, although most older adults pay the premiums. Okay, so Medicaid. Medicaid was established in 1965. Primary population is the financially indigent. The majority of Medicaid recipients are women and children, administered by states under broad federal guidelines, which covers about 1 in 5 Americans. Broadly defined as a system that attempts to integrate efficiency of care, access, and cost of care. If some people didn't have Medicaid, they probably would not have coverage at all. Okay, so this brings us to our DRGs, which I mentioned earlier in the lecture. And DRGs is diagnosis related groups. DRGs, they're predetermined payment schedules that reflect historical costs for the treatment of specific patient conditions. So with DRGs, hospitals join the prospective pay system, or PPS, whereby they receive a specified amount for each Medicare patient's admission, regardless of the actual cost of care. And that is on page 243 in your textbook. So please make sure you go ahead and take a look at it and understand what DRGs are. Prospective payment system that's in an effort to contain costs. Okay, so PPS, cost containment effort. So, as a result of the PPS and the need to contain costs, the length of stay for most hospital admissions has decreased significantly. I remember in my early days of nursing, a hospital stay to have a baby was 5 to 7 days. That's pretty expensive. It is nowhere, it's at least half of that right now. So it has changed significantly where patients would stay in the hospital longer. They're going home sooner. And it also decreased the risk of, hospital acquired infection that they can get from staying in the hospital for a prolonged amount of time. And so the hospital stays are definitely shorter. HMO, Health Maintenance Organization. This is on page 244 in your textbook. So go ahead and make sure you take a look at that as well. All right. So, what are critical pathways? Critical pathways are predetermined courses of progress that patients should make after admission for a specific diagnosis or after a specific surgery. Strategy for assessing, implementing, and evaluating the cost effectiveness of patient care. Critical pathways are good because they also standardize patient care with similar diagnosis. Many providers call this the cookbook medicine and refuse to participate because it's a recipe. If a patient has diabetes, this is the protocol, this is the standard, and this is what we're going to do. Um, okay, all right. Utilization review, a process used to assess the need for medical care and to ensure that payment will be provided for the care. So, case managers and documentation specialists who review concurrently what is being documented and make suggestions for improving documentation to capture higher rate or more accurate reimbursement. Okay. Provision of service no longer guarantees reimbursement. Clear and comprehensive documentation of the need for services and actual services provided is needed for reimbursement, which I stated. Why does the patient need this? The doctor, usually the primary care doctor, will document why the patient needs it, and then it has to be approved before the services are provided. So the same for reimbursement. Some patients need, care that may be um, life changing or life saving for them, and they have to get it. And sometimes they're not always reimbursed or even always approved for the service for that matter. And that's often seen in rehab services and in doctors' offices. And I could use from my experience as a veteran. So if I needed specialty care that the VA hospital cannot provide, they will put in a referral for what we call a community care partner. And the community care, they'll put in a referral. If it's approved, there's a certain time limit that you have to use it within. And if it runs out, that time expires and you still need a service, you have to go back through the process again of seeing primary care, having that approved by the time it gets over to the community care partner. So the process can be a bit daunting. Okay. And I would just ask that you review this slide, this one, and this one, this one, and this one, this one, and this one. We won't go into depth in those in the lecture, but just take a look at them when you have an opportunity. Um, and page 251, this particular side, ACOs, take a look on page 251 in your textbook. reviewed this one. And then for this one, the medical home relies on a team of providers to integrate all aspects of healthcare through well-developed health information technology, including electronic records. This is often used in the military that I've seen from my experience. I actually worked at a clinic in Japan where we used the medical home model for our health care. Hey, health insurance marketplaces, also called exchanges, are online insurance supermalls created for individuals without access to health insurance through a job or for small businesses who wish to buy affordable and qualified health benefit plans in a competitive insurance marketplace. So as we know, healthcare is expensive, and this is an option for individuals. They still need health care, so this is an option for them to get health care, if it's affordable for them.